Welcome to our video on neural tube defects, anencephaly, and Potter sequence. So we'll start with the neural tube defects. Neural tube defects result when the rostral or caudal neuropores of the neural tube fail to close by the 4th week of gestation. And these are actually associated with diabetes and folate deficiency during pregnancy. And there's several subtypes of these defects. So there's spina bifida occulta, spina bifida cystica, and that actually can be subdivided into meningocele and myelomeningocele. There's also myeloschisis and anencephaly. So we'll discuss these subtypes on the next several slides. Now, spina bifida occulta is caused by failure of the vertebral arch to fuse around the spinal cord. And this defect is usually at the lower back, so specifically at the L5 to S1 vertebral level. And at that location, there might be a skin dimple or a tuft of hair, and that would indicate spina bifida occulta. Now, in contrast to all of the other types of neural tube defects, spina bifida occulta is characterized by a normal alpha fetal protein, so a normal AFP. And there's also normal acetylcholinesterase. In other words, in the amniotic fluid, you won't have any signals via abnormal AFP or acetylcholinesterase levels that would indicate that there's a neural tube defect. So here we see the classic appearance of spina bifida occulta. So as indicated here, you can see a tuft of hair or a skin dimple. And of course, this would be at the lower back. And just by way of review, what level would you be thinking of? The L5 to S1 level. So now let's move on to another type, spina bifida cystica. Now, just like spina bifida occulta, this is also caused by failure of the vertebral arch to fuse around the spinal cord. And this defect is also at the lower back. And once again, we're thinking the L5 to S1 level. So this one is characterized by a cyst covered with thin skin. And there was a couple different subtypes. The meningocele has a cyst containing only meninges, while myelomeningocele has a cyst containing both the cauda equina and the meninges. But what are the AFP and acetylcholinesterase levels in the amniotic fluid? Well, there's actually high AFP, but normal acetylcholinesterase. So now let's do a quick question. A 28-year-old G1P0 female comes to the physician at 28 weeks of gestation for a routine prenatal visit. Her pregnancy is uncomplicated. She has a history of epilepsy treated with carbamazepine. Transabdominal ultrasound shows a cystic enlargement at the lower back of the fetus. What changes are expected in the levels of AFP and acetylcholinesterase in the amniotic fluid of this patient? Okay, so this patient's transabdominal ultrasound shows cystic enlargement of the lower back of the fetus. Additionally, the patient is taking carbamazepine. Now, the reason that carbamazepine and many other anti-epileptic drugs are associated with neural tube defects is because they disrupt folate metabolism, so effectively causing a folate deficiency for the fetus. So which neural tube defect is most likely here? Well, because of that cyst that was seen on ultrasound, we think of cystica. So spina bifida cystica. So if we're thinking of spina bifida cystica, what would you expect the alpha fetal protein level to be? It would be high, while the acetylcholinesterase level will be normal. Here we see a classic appearance of spina bifida cystica, specifically myelomeningocele. Notice the cyst located on this patient's lower back. Now let's move on to myeloschisis, which is also known as racheschisis. Now, myeloschisis is caused by the failure of the neural tube to close. So the skin would actually be continuous with the neural tissue at the lower back. In other words, the dermal and meningeal coverings are absent. And myeloschisis has high levels of both AFP and acetylcholinesterase in the amniotic fluid. This image demonstrates myeloschisis, and hopefully you can appreciate the neural tissue and how it's continuous with the patient's skin. Now let's discuss anencephaly. This is caused by a failure of the rostral portion of the neuropore to close. And it makes sense that it's rostral because it's the head that has the problem. So there's not going to be any forebrain, and that calvarium is open. So again, the rostral portion fails to close. And the fetus ends up having this frog-like appearance, especially with the head, due to the relatively large size of their fetal eyes. And this condition is characterized by polyhydramnios because of the absent fetal swallowing center. So part of the brain is missing that would cause the patient to swallow. So that fluid builds up in the amniotic cavity, so polyhydramnios. And just like myeloschisis, anencephaly has high AFP and acetylcholinesterase. So here's an image of a patient with anencephaly. And you can see the open calvarium, so that rostral portion of the neuropore just failed to close, and those fetal eyes look relatively large, which is why some people say that the fetus with anencephaly often has this frog-like appearance. Lastly, let's talk about Potter sequence. Potter sequence is caused by oligohydramnios, so a low amount of fetal fluid, and that in turn compresses the fetus. So any condition that causes a decreased amount of amniotic fluid or oligohydramnios can actually potentially cause Potter sequence. So some of these conditions are autosomal recessive polycystic kidney disease, or ARPKD, and bilateral renal agenesis. But why would those cause oligohydramnios? Well, it's because most of the amniotic fluid is made up of the urine of the fetus. So if there's a kidney issue that results in decreased urine production, then that could lead to decreased amniotic fluid and Potter sequence. Similarly, posterior urethral valves can also cause this condition because that misplaced valve means less urine being put into the amniotic fluid. And placental insufficiency can also cause this problem. And that's because less fluid is making it to the fetus from the mother. And if there's less fluid in the fetus, there's less to urinate out. Okay, so what actually happens to the patient that we call Potter sequence? Well, if you think of the amniotic fluid as a cushion that protects the fetus, then less of it means less cushion protection. So what ends up happening is that fetus is just compressed more. And so as it grows, it gets deformities. For example, the limbs will be deformed. And also there will be some facial defects, like a flattened nose and a retracted jaw, also known as retrognathia. And most importantly, a fetus with Potter sequence has pulmonary hypoplasia. And that's actually the most common cause of death in this condition. As you may recall from embryology, amniotic fluid aspirated in fetal lungs is necessary for that proper distension of the lungs and development of the lungs. So if there's not enough amniotic fluid to basically inhale, so to speak, then those lungs will not mature appropriately. So when the fetus is born, then that neonate might actually develop neonatal respiratory distress syndrome. And that's actually the most common cause of death in these neonates that had Potter sequence. And here we see the newborn with Potter sequence. You can see the retracted jaw, the deformed limbs, and that flattened nose. And it just makes sense that this fetus is just getting squished. It's not enough cushion. Okay, let's wrap up with a question. A 2-year-old boy is transferred to the neonatal intensive care unit due to labored breathing. He was born at 39 weeks of gestation via vaginal delivery. Mother was told on one of the prenatal visits that both of his kidneys were missing. The physical exam of the newborn shows a flattened nose, retracted jaw, and twisted extremities. Despite resuscitation, the patient dies 3 hours later. What is the most likely cause of his death? Okay, so the neonate we see has classic symptoms of Potter sequence, that retrognathia, flattened nose, and twisted extremities. And we also know why the Potter sequence occurred. It's because the fetus was missing his kidneys. And the neonate only lived 3 hours. What was the most likely reason for the patient's death? Well, as we mentioned on the previous slides, it was most likely due to pulmonary hypoplasia, because lack of development of the lungs is actually the most common cause of death following Potter sequence in utero. And that concludes this section.